Good afternoon, everybody, and welcome to the Calderdale and Kirklees Joint Health Scrutiny Committee. Apologies for absence today. We've got Councillor Andrew Cooper, Councillor Richard Eastwood, but Councillor Munro is here instead, and Councillor Howard Lakeborough from Calderdale. Right. Can I first of all give the usual announcement about filming? So, the Openness of Local Government Bodies Regulations 2014 have been approved by Parliament, allowing the public to film, tweet and blog at meetings of the Council. Consequently, Kirklees Council has agreed to allow recordings to be made at all meetings of the authority which are open to the public. Any persons wishing to record proceedings are asked as a courtesy to inform the Chair prior to commencement of the meeting. Recordings may only be taken overtly and from the designated public area, and the Chair has the authority to instruct that recordings be stopped in any instances where it becomes disruptive or is distracting to the order and conduct of the meeting. And we haven't had any requests for today's meeting. Okay, all right. The aim of today's meeting is for the strategic outline case to be presented, and then for the committee to discuss the next steps in the scrutiny process. That is what our aim for today is. So can we move on first of all to the minutes of the previous meeting? Now we've had submitted some suggestions for amendment to the minutes of the meeting. So, at page 2 of the minutes of the 15th of February, there is on the first bullet point under members discuss the following issues. The number of hospital beds would be maintained, and then until an estimate could be made of the number of beds which could be reduced, it's suggested to be changed to broadly as they are now, until there is clear evidence that demand for hospital beds has reduced. Are we okay with that amendment? Yeah? Yeah. The next one, now quite a lot of these are questions that have been put and then the answer that's been given. So the next one, it's a change to the question has been suggested. So there would be an accident and emergency department provided at Huddersfield. There would be an accident and emergency department provided at Huddersfield would change to an urgent care unit. What was the difference? So I think we would like to keep the question that is there because that's what was asked by the scrutiny member. But then the response, officers advised that there would be a staff presence 24/7, consultants would be available, and there would be a full resuscitation service. Would we want to put officers advised that there would be an accident emergency department with a staff presence 24/7? Would that help? Yes? Okay. And then the bullet point that starts, would the resuscitation services at Huddersfield extend to cover children? In response, officers advised that children's care would be available at Huddersfield. And we had put in that experts in children's care would be available in Huddersfield. And we'd like clarification as to why the suggestion is to take out the word experts. Could you just clarify that for us, please?
I suggested changing that to remove the word experts because it suggested that we were saying there would be specialist paediatric care at Huddersfield, and the proposals are for specialist paediatric services to be provided in Calderdale at Halifax. So I thought there was scope for confusion in that. The staff at Huddersfield will have had training in caring for children in an acute setting, but they will not be specialist paediatricians.
I think it would be, we can all foresee the scenario where a parent with a child in status asthmaticus or some other severe acute problem, bundles their child into the back of a car and drives to the nearest hospital, which could be Huddersfield Royal Infirmary. And we were wanting clarification that there would be proper paediatric resuscitation facilities there at Huddersfield Royal Infirmary, rather than having to summon an ambulance and take them across to Calderdale Royal. And that was the nub of the question.
So I think to clarify, we will, as I think we said at the last meeting, we will have people who are trained in paediatric advanced life support present in the Huddersfield Accident and Emergency Centre, along with anaesthetic cover, who would be able to stabilise patients, paediatric patients, prior to ongoing transfer and ongoing care in Calderdale.
So would you be happy for that to be clarified in those minutes, along the lines of what you've said?
Yeah, I think that would be fine.
Thank you.
Yeah. So the clarity will be made, okay, in the minutes. Is that all right with everybody? Yes? Okay. There's nothing on page 3, but then on page 4, the first bullet point towards the end, there's about 3 lines that suggested to be taken out. This model was based on existing schemes and 10% of beds would be taken away. It was believed that this number could be increased further as a result of shared services. Capacity modelling was already being done, and it's suggested to be changed. This model was based on existing community schemes, full stop. Now, bearing in mind that these minutes are as of February, okay, so it's not what has happened in the interim period, it is what is as of February was the situation. So again, we would like clarity on why the suggested amendment has been made, please.
I suggested an amendment because when I read the minute, I interpreted that it was saying that the model of care that we are proposing is based on us reducing beds by 10%, which is not correct. We are proposing to maintain our bed base currently as it is now.
I think in your strategic outline case, you add something else onto that. There's a sentence that's added on. There's some words added onto that, which will come to under the strategic outline case when we get to that. But I think in this instance, this model was based on existing community schemes. Did you not at the time say, and do you not in your SOC say, 10% of beds could be changed? And at that time, had you actually reduced some beds in any case by work that had already been done?
In the SOC and the position, we talk about that we'll maintain beds broadly as they are now. As years go on, likely demographic increases in demand, the existing community services we have in place, some modelling work has been undertaken to show that will more than be able to absorb that demographic demand at circa 10%. I read these as meaning there was a more direct, we intend to take 10% of our beds out. If I've misread that, and others don't read it that way, but I thought it was misleading. I didn't want a suggestion to be there that we are planning to reduce beds by 10%.
I'd welcome that. I welcome that clarification. But it does mention both on page 16 and page 119 of the SOC that the intention is a 10% reduction in non-elective bed days, and that's part of the capacity modelling that you've gone through. So that's why I wondered why it was in the SOC, but then being removed from the minutes. But if that's no longer the case, then I very much welcome it.
I'd reiterate the 10% is about our resilience regarding future demand, as opposed to today saying we will reduce by 10%. It's about saying going forward there is a resilience around the ability for our existing community services to reduce that demand over those years.
So Matt Walsh here from NHS Calderdale CCG. There is a distinct difference, Colin, between the notion of reducing non-elective bed days and that then being translated into beds out. They are not the same thing. I think that's important to recognise.
Would this be actually 10% of bed days?
I'd reiterate, we're not planning to say from a position today we will reduce beds. We're saying as we move forward there will be, and anticipated, the demand will be mitigated by the capacity of our current community services by the equivalent of 10% of bed days.
So this model was based on community services rather than schemes. Community services, that would result in a reduction of 10% of bed days. Of anticipated. And anticipated 10% of bed days. Yes, that would clarify it, but I think that it is in there because 10% has been said. Okay, so I could understand if beds and bed days may have got mixed, but 10% would have been definitely said. Okay, so I think if we clarify it in that way, yes, is everybody all right with that? Okay. Then the digital technology was mentioned in the update to the Secretary of State. Now, remember this is of February, and we've put this was an issue as GP surgeries could not see hospital records and vice versa. And what the suggestion is, this was an area of development as GP surgeries could now see hospital records. So in February, could GP surgeries see hospital records and vice versa?
Yes, that was implemented during February. So this first part is the question, right? So were there any opportunities in this area? Question mark. Could committee members visit to see technology functions in action? Question mark. Right? That part of that is the question. In response, officers advised that technology was moving forward and systems were now more functional. GPs could access hospital records. So what you're saying there is, what you've put up at the top, that GP surgeries could now see hospital records. It says GPs could access hospital records down there. So instead of it altering the question, could we clarify that GPs could access hospital records and vice versa? Is that what you were meaning you said? Yes, that would clarify it. I've corrected the question. It's helpful. Thank you.
I did have the opportunity to visit the Trust a couple of weeks ago to see how things were developing with the ability for records to be shared between primary and secondary care, and great progress has been made since I last saw it in December. It's still work in progress, but it was certainly getting much closer to what was being envisaged.
Is everybody all right just with that clarification on that part? Then the next one, about concerns about vacancies for radiologists. Again, this is a question, but it says 200 were needed, and what we think 200 are needed nationally. So we're suggesting there that we put in the word nationally to clarify it's 200 nationally that were mentioned as part of the question. All right? Yeah? And then the next bullet point, it was common for commissioners to reduce services that are not being performed. The response officers advised they were working on hyperacute stroke services at the moment. People will need to be transferred, but this is what happens now. Now, this was at the time in February when hyperacute stroke services were actually being discussed, and I think what was meant there was people would need to be transferred from HRI to Huddersfield, to Calderdale, wouldn't they? But that is what happens now. So, in actual fact, that was correct, that it wasn't actually the CCGs that were making the suggested changes, it was actually NHS England, was it not? Because it's a regionally commissioned service. So, it was... the question was, it was common for commissioners to reduce services that are not being performed. In response, officers advised that regionally work was ongoing on hyperacute services at that moment in time. Yes? And people would need to be transferred from Huddersfield to Calderdale as they were currently. Yeah, Colin?
Thank you. At the time of this meeting in February, the reconfiguration of hyperacute stroke services across Yorkshire was still in active discussion. So this question refers to how things were then. I know that since February, the decision has been made to maintain a hyperacute stroke service in Calderdale, and so, but this is a historic document as to what questions were actually asked at the time, but obviously things have moved on since then.
So if we just clarify that it was regionally being looked at, yeah, and that the transfers are between HRI and Calderdale, which is what happens currently. That's what happens in February, yes? Would that clarify your point? Because it was asked, it was answered, and therefore it needs to be in the minutes. Is everybody all right with that clarification? Okay. Page 5, the engagement process was lengthy, and officers advised there were no, and the words current interim inserted instead of officers advised there were no plans for reconfiguration and they were engaged if the need arose. Are we all right with the officers advised at that time there were no interim plans for reconfiguration? Yeah? Presumably the clarification is there were plans for reconfiguration, but there were no interim plans at that time to move any services in the meantime. That's what the clarification is about. Yeah? So if we just clarify that. All right? So that comes to the end of the minutes. Is everybody happy with that? Yes? Okay, thank you. Right then. So, I haven't moved off item 1 yet. Right, interests. Does anybody have any interests they wish to declare?
Sorry, I'd like to declare an interest as a member of the member board at Calderdale Royal.
Thank you, Councillor Swift. Yeah, Councillor.
And I am a member of the Calderdale Huddersfield Foundation Trust.
And just swiftly moving back to the minutes, I did forget one change at item 10, interests. Councillor Stuart Turner declared an interest as she had a close family member instead of he. Right, okay. Let's not forget that. Right, thank you very much. Admission of public, all debates are in public, so we agree to public being present to everything. Deputations and petitions. I bet you wondered if we were going to get there, didn't you? Right, okay. So, deputations and petitions. The first one is Councillor Warner, if you'd like to.
Right, hi. I'm a relatively new councillor, as in elected only in May. And I'm not about to speak on the minute detail because I'm not familiar with all of it. But what I do know, in campaigning, which we did really thoroughly, regularly, all weathers throughout the ward in Colne Valley, The number one issue that is worrying everybody, it was on the doorstep over and over again, is the loss of acute services. A lot of old people are worried, they're marginalised, we know all the issues with social care, and we, with the best will in the world and all your new visions of what may or may not happen in the future, their immediate future, which for some of them might be 2 years, 5 years, 10 years, they want to know that if there's a heart attack, if there's this, they can go in and there will be fully staffed acute service provision with fully qualified doctors, not 24/7 partially trained people. And I think it's really important that, particularly in the current climate, if there's an opportunity to relook at this, there should be one. Because I tell you, right across the political spectrum, everyone I talk to continually asks about this. And I made it a number one pledge when I was standing. And I thought it was important at this give you this opportunity to say I'm going to be fighting on every way I can to ensure that this acute services get maintained.
Can I just clarify, this is scrutiny? So
Sorry?
This is scrutiny, okay.
Right,
I know it is. It is scrutiny, okay. All right, thank you. Stephen Slater.
All right, okay, thank you. Good afternoon. I'm Steve Slater, resident of Marsden and co-secretary of the Hands Off HRI campaign. At the public meeting of the committee in February, I queried the nature of the proposed A&E at HRI as described in the strategic outline case, in particular whether it could be considered a Type 1 A&E. As we've seen earlier in the meeting today, the committee, I know, are pursuing the issue actively. I hope my submission today may assist them in that. Huddersfield, particularly in its more outlying areas, such as Marsden, where I live, the nature of the A&E really is key. Is it to be a proper A&E, one able to treat critically ill patients in a timely fashion? Our discussions and feedback from members of the public are quite clear. People are expecting nothing less than a fully functioning A&E. Our concern now is that the A&E proposed in the SOC, an A&E not specified by IRP recommendations, so one therefore assumes proposed in response to public pressure and disquiet, it will not in fact have the necessary clinical codependencies essential to the proper and safe functioning of any A&E. It has to be said, a potentially unsafe proposal without the necessary critical care facilities and staff, and where critically ill patients have to be removed to CRH, will satisfy no one. The question of clinical codependencies for A&E departments has been considered by, in particular, the South East Coast Clinical Senate and the King's Fund. The SECCS carried out an extensive review of the evidence base and a comprehensive clinical review of interdependencies between acute services and A&E departments, including those A&E departments not taking acute surgical patients. They concluded that necessary on-site services required to support any A&E department include acute medicine, respiratory medicine, urgent GI endoscopy, upper and lower, cardiology, trauma, adult critical care, urgent diagnostic haematology, and acute mental health services. Similarly, the King's Fund review of evidence on service reconfiguration finds that key clinical and service interdependencies for A&E departments include critical care, acute medicine, acute surgery, paediatric expertise, and access to inpatient beds. The SOC Estate Section 7 notes that HRI is currently the centre for emergency surgery, planned complex surgery, and emergency paediatric surgery. Under the future service model, however, these specialties are to be removed to CRH. All blue light ambulance cases will go to CRH, as will cases requiring complex surgery or critical care after surgery. HRI will retain an A&E for walk-in patients, of whom we must remember a small proportion will be critically ill and need rapid and comprehensive emergency care. So, given the A&E on-site clinical codependencies specified by such august bodies as the King's Fund and SECCS, many or most of which are lacking from the SOC proposal for HRI, we request first that the committee urgently look into the matter Secondly, which I appreciate you are doing, but just to reinforce that. Secondly, take it up with the Trust and CCGs as appropriate. If the Trust is genuine in its proposal for an A&E, not just an urgent care centre at HRI, it's vital that it commits to providing on-site and with appropriate staffing the necessary clinical codependencies. Turning now to SOC Section 6 capacity impact, dealing with the key issue of hospital capacity at both hospitals, including bed numbers, it said that to arrive at the conclusions, only a high-level review and refresh of previous work was done, with further work to be done at OBC stage. And regarding 6.1 activity growth assumptions, it said that a downgraded growth forecast was not based on individual specialty growth assessments, but only agreed at point of delivery level. I'm not entirely clear what that means, but it does seem to imply it may be something of a guesstimate. It's also noted that discussions are still to be had with YAS on clinical protocols for ambulance diverts. While I appreciate this is the strategic outline case, we do ask that the committee assures itself that the Trust and CCG's assessment of clinical and physical capacity is realistic and robust, and whether further work may actually be needed prior to OBC stage. Thank you.
Mike.
Thank you, Chair. Mike Forster. I'm Chair of Hands Off HRI and a resident of Crossland Moor. I have a number of questions that I wish to address to the Trust management as well as to the committee. In your new business case, you rely heavily on the findings of the Travel and Transport Group, which was established in May 2017, and it was asked to consider your original full business case of 2017. As we know, that's now been vetoed by the Secretary of State, and you've developed a new business case, which we're discussing today, which publicly claims to have 2 A&Es and 2 hospitals. Therefore, how relevant is the original travel and transport plan, since you claim to have the majority of services based on 2 sites? Now that you have a so-called new business case, surely you're also going to need a new travel and transport plan. You say that the plan should be regularly highlighted in the local NHS communications strategy. Will you have an update for us today? The Travel and Transport Plan also referenced the joint CCGs bringing in a steering group to oversee this work. Has this been set up? Has it begun its work? If so, what are its plans? You also refer to a multimodal corridor improvement plan. Has that now been prepared? What is it? And has it been produced? You correctly anticipate that the parallel transport projects are, in your own words, complex and challenging, and so far we've been unable to see any immediate improvements. The Ainley Top roundabout has been upgraded, but the bottlenecks have become worse and are now being re-evaluated. Do you have any update for us today on that work, or any review of its efficiency? The work on Salterhebble Hill has now been completed. As we see it, the work has improved traffic flow for around 100 metres going up the hill to CRH, but then you re-enter a bottleneck approaching the traffic lights. These improvements have not touched on the major bottlenecks which are on the A629, when the dual carriageway dovetails into a single lane for approximately half a mile. Traffic soon backs up and can lead to considerable delays. Are there any plans at all to upgrade that part of the A629? The other bottleneck which has not been considered at all is traffic flow on the M62. There are regular accidents and bottlenecks on this immediate stretch of the motorway which impact on local networks and can bring traffic to a halt in the vicinity where there are partial or full lane closures on the M62. How has this been considered in your plan? What mitigation is in place? The journey time analysis carried out by the Travel and Transport Group was a desktop analysis, backed up by a survey of A&E visitors over a 1-year period. I have 2 direct questions with this methodology. 1, are you satisfied that the desktop analysis corresponds directly with patient experience, since you currently acknowledge that transport was a key factor in public responses to your original consultation? Our direct experience of travel between hospitals is hugely variable. It is the minority of cases which, of course, will end up being the emergency. For example, the group concede that transport time can be 40% greater than the claimed average of 13 minutes. The group also described 4% of patients are in a high maximum transport band where journeys can take up to an hour. How have they arrived at the figure of 4%, and how many of the population does that actually cover? You no longer propose to reconfigure just A&E services, but all services, so travel and transport will impact on a larger group of patients. How do you propose to reconsult that group, since the travel and transport group claimed that they would ensure public voices were prominent? Regarding the shuttle bus service, the group and yourselves acknowledge it's not fit for purpose. This is a service which prioritises staff, not patients. It does not run on time. There is no wheelchair access. Young people under 3 cannot travel with the bus. Do you agree this is discriminatory and dangerous? What immediate plans do you have to improve this service? Ambulances are now routinely taking Huddersfield patients to Halifax, and they have to find their way home. How is this now being addressed? The Transport and Travel Group acknowledge they have no meaningful data on visitors, but surely this is a key factor in maintaining family support and recovery. Visitors are not a priority on the shuttle bus and always struggle with public transport and/or parking. This is an immediate problem. How is this being addressed? Finally, on car parking space, you have plans to use another private finance initiative or public-private partnership. You already have one of the worst PFIs in the country, and the government has said there will be no more PFIs or PPPs. How do you intend to square that circle? And can you give us an update on the Transport and Travel Group's recommendation that will improve the following: reconfigure the shuttle bus into a local bus service, develop a high-frequency service linking bus and railway stations, develop the...
Thank you, Mike. Right. Okay, Christina.
Yeah, I won't take that long. I'm going to be short for a change. We should all remember that this revised proposal has been undertaken as a direct result of the intervention of the then Secretary of State, who was clear that the original proposals did not serve the people of Huddersfield. Having read the document, I failed to see that in key areas this strategic outline case differs dramatically from the original. The words may be different and we may be keeping the building, but the result is very much the same, with Huddersfield losing all acute services to Halifax. Members of the committee will also recall that the Hands Off HRI campaign was granted permission for a full judicial review on the initial proposals for the reconfiguration. In his findings, the judge agreed there were 5 separate counts of law which had to be tested at full judicial review. These included the financial sustainability of the full business case, inadequate consultation and failure to consider relevant factors, the proposed reduction in hospital admissions, the impact of the changes in relation to travel and transport for patients and their families and carers, and public sector equality duty. I think Mike has covered very much the travel and transport, and the financial sustainability we will come to. But I would hope that these 5 issues are fully addressed in the ongoing process, both in the planning by the Trust and the scrutiny by elected members, and in future engagement with the public. In the section on stakeholder and public engagement, there is talk of fully engaging and involving local people, but no formal consultation. I have a question as to whether this committee feel that that is sufficient, or whether there should be much wider public consultation. And I would ask how the committee, as representatives of the people of Huddersfield and Calderdale, ensure that the revised proposals ensure that the general public have their say, and that the Trust and CCGs actually take notice of the responses. It is also noted that the proposed reduction in hospital beds due to reliance on care closer to home, set out in the original proposals, is not included in the strategic outline case, with the bed numbers remaining more or less the same, although we will see an increase in Calderdale and a reduction of beds in HRI, and a new building in Calderdale for those beds, and presumably part of HRI being mothballed, which I fail to see the logic of that, actually, if we're spending money. At the last meeting of this committee, Dr Walsh agreed to share data that will be used to assess the improvements needed that would allow a reduction in hospital beds with Councillor Hutchinson. Has this now been done, and if so, can it be shared with other committee members and the general public? And even if those figures aren't about the reduction in hospital beds, but as you were talking about an increase in demand, we still need to know what that data is and how it will impact, and whether or not there are primary care providers actually agree with some of the data that will be used. It's also noted that in 3.7 of the strategic outline case, Calderdale now ranks 21st out of 150 local authorities nationally on delayed transfer of care, and you should be, that should be applauded. Can this committee ensure that we have the same ratings for Greater Huddersfield and that this is shared with the public? It's fine Calderdale becoming 21st, but this committee is about both Calderdale and Huddersfield, and we need to ensure that we see improvements on both sides. That's it.
Jenny.
Thanks. Hi, my name's Jenny Shepherd. Before I start my statement, I'd just like to refer back to a question about the accuracy of the minutes, and it was the question about whether the CHFT is able to access GP's data and vice versa. And at the Brighouse engagement event on June the 11th, I spent quite a lot of time talking to Dr. Nigel Taylor from Hebden Bridge Group Practice about this, and he was saying one of the problems is that the hospital can't access GP's data, and I said, why? Is it a problem with the kit or what? And he said it's because CHFT staff aren't trained. Okay, aren't trained in how to access GP's data, and that wasn't mentioned here, so I thought I'd just mention it as something that Dr. Taylor said to me. We had a long chat about it, actually. So to get onto my deputation, it's about the financial bits of the strategic outline case. And we first like to start by saying that Calderdale and Kirklees 999 call for the NHS still dispute the assumption that there's a compelling case for change for cutting and centralising our 2 district general hospitals, because we see this as based on an ill-advised political choice to cut public spending that was made following the global financial crash and the bankers' bailout. We think that 2 full district general hospitals with full 24/7 A&E remain the best option for the people of Calderdale and Kirklees, and we are convinced that nationally we have the money to pay for them. As a country with a sovereign currency, the government creates money by spending it, as it did to bail out the bankers. So if it can bail out the bankers, it can and should bail out the NHS. And in doing so, it would multiply by 3 times the amount of its investment that would circulate in the economy, since 3 times is the multiplier effect of spending on health services. And this would be unlike the bankers who just sat on their bailouts and did nothing economically productive with all that huge amount of money. To get onto some specifics about the strategic outline case, we'd like to know what opportunities for cutting costs are provided by Model Hospital Carter, which we actually thought had now been superseded, getting it right first time in NHS benchmarking. We'd like to know how much additional commercial income is projected from Huddersfield Pharmacy Specials, the Health Informatics Service and the wholly owned subsidiary company. We'd also like to know if additional income is projected from patient-funded elective procedures, as was stated in the previous full business case. And finally, does the pressure resulting from being unable to make the required cost improvement programme savings last year threaten the Trust's ability to meet its control total this financial year? NHS England and NHS Improvement have said that they will devolve powers of regulation, oversight and assurance to West Yorkshire and Harrogate Integrated Care System. And the Integrated Care System Partnership Board Memorandum of Understanding shows that these powers include making recommendations on recovery plans for NHS organisations that are in deficit, appointing a turnaround director and team, and restrictions of access to discretionary funding and financial incentives. It's clear that the overall intention is to cut costs and restrict patients' use of the NHS, and to make the unaccountable integrated care system responsible for doing that, not the NHS quangos. An example of discretionary funding and financial incentives is the 28.2 million of funding that depends on Calderdale and Huddersfield Foundation Trust meeting its financial control total. And our question is, how is it right that the integrated care system, which is an organisation with no statutory powers or existence, how is it right that such an organisation has these regulatory powers over our hospitals? What is that going to mean for democratic, accountable, transparent control of our public organisations? Thank you.
Rosemary.
Hello, Rosemary Hedges, NHS supporter and campaigner. I want to talk about primary and community health services. The strategic outline case says that the only way that the hospital can meet the control total is to transform hospital and community services. So the transformation of primary and community health services appears to be driven clearly by the need to make cuts and to free up hospital resources so that hospitals can cope with current and predicted demand. As key building blocks of this transformation, the 14 care networks that the CCGs have rushed through in Calderdale and Kirklees without any public consultation appear to be intended to cut the costs of primary and community health services. And the same goes for Calderdale Care closer to home and the Kirklees equivalent. Is this banging? The 5 Calderdale primary care networks are key to a new integrated care alliance, according to the Calderdale Care Closer to Home commissioning prospectus. The prospectus includes the statement that under the Integrated Care Alliance, clinical responsibility for all patients within their own homes, including residential and nursing, will no longer sit by default with the patient's registered general practice. So the question is, who will be responsible for patients in their own homes? I understand this matter is currently up for discussion, but it is of concern to know the question is even being asked. Hebden Royd Town Council in Calderdale has expressed concerns about the transformation of community services and wrote to Calderdale CCG asking them to put the important topics of primary and community health services on the agenda for conversations at the Brighouse stakeholder engagement event on 11th of June, but this didn't happen. The topics Hebden Royd Town councillors wanted to know more about were these: what is going to change about access to GPs and to consultations with GPs? This has changed significantly of late, with new models being introduced. Have these models been evaluated, and what lessons have been learned, and will they be applied? How will the introduction of the primary care network contract affect patients' right to continuity of care with their named GP? We know from research that continuity of GP care extends lives. Is access to elective services through GPs going to be restricted further? This development in recent times has caused much concern. We are seeing a shift to self-care and the placing of more responsibility on the shoulders of the individual. Can you explain why this model is being applied and why it is felt that individuals are not already taking responsibility for their health and well-being? And finally, as we see an increase in the use of third-party apps, is access to healthcare likely to become conditional on the use of this equipment? And will the privacy of the individual be respected if this use does grow? What are the risks of patient data inadvertently or by design falling into the hands of outside agencies? Thank you.
Thank you very much. If anybody has a written deputation that they wish to hand in to the officer to be circulated to the committee, please do so. Okay, thank you. Item 5 then, the financial update from CHFT. Is somebody going to introduce this? Thank you. Do you want to say who you are to start with, please? Thank you.
Okay, hello everybody. My name's Kirsty Archer. I'm Deputy Director of Finance at Calderdale and Huddersfield Foundation Trust. And so I won't spend too long on this because I'm conscious that a lot of your questions surround the future, and this is very much looking retrospectively and at where we are now, but it sets the context. So starting off looking at last financial year, which was 2018-19, and touching on some of the questions I think around the control total and access to national funding. So last financial year we planned for a deficit of 43.1 million. That planned deficit was not in line with the NHSI, that's NHS Improvement, our regulators, the control total that they set for us. In not accepting the control total, we were precluded from accessing certain elements of central government funding, so something called provider sustainability funding. Having said that, we planned for a 43.1 million deficit and we achieved a 43.1 million deficit. We achieved that by delivering a level of efficiencies of £18 million. Those efficiencies were all reviewed through quality and equality impact assessments, and so they are fully reviewed before being implemented. Another success during the course of last financial year was that we managed to reduce the level of agency expenditure, so that's agency staffing expenditure, reducing it both from our planned level and from the level that we spent the year before. So that set us in a good place for moving into 2019-20. As we've moved into 2019-20, a considerable proportion of the savings that we made last financial year were recurrent, which means they're ongoing savings, and so that set us in a good place. The control total that was set by NHS Improvement for this financial year was just under £38 million, and we were able to accept that control total, so in a different place than we were last year. Off the back of accepting that control total, that gives us access to be able to draw down some central government funding. So there's a number of different pots that comes from: the marginal rate emergency tariff, provider sustainability funding, and because we are a trust who continues to operate with a financial deficit, we also qualify for financial recovery funding. The total of those three pots of money is the 28.3 million, I think was referenced in one of the questions. What that does is it comes in and it improves our deficit position, moving it from the £38 million to £9.7 million, considerably reducing the deficit. It doesn't mean that we can therefore spend another £28 million. Effectively, we've already spent that money, and what it's doing is reducing the scale of deficit that we carry on our books. But the good news is that in receiving that funding, we receive cash, and so therefore we pay less interest. Again, in order to achieve that position this year, we will have to continue to deliver savings. The level of savings that we've got planned for this financial year to achieve those plans is £11 million, which is evidently significantly less than the 18 million from last year. And the good news there is that as we moved into the financial year, we did have the entirety of that £11 million identified, and so that in terms of the risk levels that we're carrying this year, they are more balanced perhaps than we've seen in previous years, in that we've been able to identify the full range of savings at this early stage of the year. As with last year, all of those efficiency programmes will go through quality impact assessments and equality impact assessments to make sure that their impact to service delivery is positive. I think that's probably the overview, and that position that we see there for 2019-20 forms the baseline of the latest financial modelling for the reconfiguration case.
Thank you. So just to check that we've got it right. You're where you've got a 43 million deficit this year, you're planning on a 37.9 million deficit in 1920, but that gets supported by funding of 28.28 million. So you still have the underlying deficit, but you've got funds in to reduce the actual deficit to 9.71 million, but you are still running a 37.9 million deficit, and therefore you cannot spend any of that 28 million. It is simply bringing down your deficit at the end of the year. So what happens if you don't achieve your savings, and what happens if you, in the following year, if you haven't managed to meet your 9.71 million target? Is there going to be ongoing funding available, or will you go back to not being able to access funding, and then your deficit will be a lot higher? So what?
Okay, as you might expect, it's not a straightforward answer because there's different parts to the equation. So there's, of the central funding, the marginal rate emergency tariff funding, so the MRET as we call it, is just over 6 million, and the expectation is that that will come into the tariff, the price that we get for our treatment of patients next year. So that one becomes more part of our normal run-of-the-mill income. The other two funding pots, whilst they are not guaranteed to us because they are based on performance and us hitting our targets, as we managed to hit our plan last year and we plan to hit our plan this year, they do remain within the whole of the NHS funding. And so whilst they're non-recurrently allocated to us, it is not an unreasonable assumption to make that they will continue to flow because they are available nationally. In terms of what happens if we don't hit our 9.7 million or our £38 million deficit this year, hit our control total, it is measured on a quarterly basis, and so if we hit our plan quarter on quarter, we get a proportion of that funding quarter on quarter, not spread in even quarters because that would be too simple, but spread across the financial year. And so therefore the likelihood, even if we did not hit our control total of £37.9 million, the likelihood is that we would only lose a smaller proportion of that central funding because it would only fall in the portion of the year where we fell short.
Does anybody have any questions on this at this moment in time? It is important for Scrutiny to take account of the financial positions of the CCGs and the Trust in relation to proposals. So that is why we needed an update on the finance. Okay. So is there any comment here?
Thank you. Obviously, we're through the first financial quarter now. Are you in a position to say how it's looking so far?
So we're, in terms of our reporting position, we're through the first 2 months. They're just closing the third month of the quarter as we speak, and when I get back to the office, we should be getting to a position of knowing month 3, but certainly for months 1 and 2 we have hit our plan, and so we're on track to hit the quarter.
And on your diagram where it showed that further focus was required because recurrent CIP savings were lower than planned, so presumably it was made up by a number of one-off savings. How is the recurrent situation looking at the moment?
So last financial year, whilst we were trying to rally the troops as such in terms of making that point that we hadn't delivered all of our savings recurrently as would be the ideal, last year we did deliver 86% of our savings recurrently, which is above the national average and considerably above the position we'd been in the year before, and so it's a positive movement. And as we stand at the moment, any non-recurrent shortfall that we saw last year has been picked up and incorporated in the £11 million savings that we need to make this year, so that's been compensated in our planning. And as we stand now in 2019-20, again, a very high proportion of our current planned savings are recurrent. Over 10 of the 11, no, approximately 10 of the 11.
Okay, if there's no more questions on... Oh, yeah. If there's no more questions at this... Oh, sorry, Councillor Collins.
Just a very quick one, because obviously this is the revenue that we're talking about. And what I was wondering was, at what point will we know whether or not you're going to be able to draw down early some of the capital funding? Or whether you can at all?
So our capital plans for this year included an element of drawdown of capital funding. Not obviously the full scale, but an element to get us started, and our capital plans are currently under review by NHS Improvement, and we are in their hands in terms of the timescales for improvement.
Okay, so when you have that information, can you let Scrutiny have that information, please?
Obviously, Calderdale and Huddersfield Solutions was set up last year, and you set cost improvement programmes for Calderdale and Huddersfield Solutions. Can you say a little bit about how they're proposing to actually meet those plans?
I don't have the detail in front of me, but typically the type of savings they make are efficiencies through things such as the use of energy, things like replacing some of our lighting with lower energy usage lighting, efficient use of staff that work within the facility services on the HRI site, and being able to make efficiencies as we do across our clinical services in the delivery of those very important support services in the hospital. We're quite happy to provide more detail about the specificity around some of those cost improvement programmes.
Thank you, that would be helpful.
Okay, all right. So thank you very much for the financial side of things. So can we now move on to the reconfiguration and the hospital strategic outline case? Who's going to lead on this one, Anna? Okay, so if you want to introduce yourself as we start, please. Thank you.
My name's Anna Basford. I'm Director of Transformation and Partnerships at Calderdale and Huddersfield Foundation Trust. You've asked if I could essentially walk through the strategic outline case. So there's a number of slides that were circulated, and I'll just briefly speak to each one. So in terms of, sorry, I'll just move, it's easier for me to look at my own than look up there. So in terms of this first slide around the background, I know that we're very familiar with the background. We started working with partners in clinical commissioning groups around the development of proposals for services in the future back in 2012. And over the period of time, you're very familiar with the scrutiny that those proposals have been through, public consultation, referral to the Secretary of State for Health, and review by the Independent Reconfiguration Panel, who provided a number of recommendations to us. That meant that in 2018, during the summer, we made revisions to our original proposals, and they were submitted to the Secretary of State for Health, and in December of last year, an announcement was made that capital funding of £196.5 million had been allocated to support the implementation of these proposals. In terms of being able to access that funding, we know that we are going to have to go through a series of staged business cases. The business case process is defined by Her Majesty's Treasury. There's very detailed guidelines around the content of each of these 3 business cases. Today we're at the strategic outline case stage, which is the least detailed of the 3 business cases. The outline business case and the full business case will build upon that level of detail. And in moving forwards, now that we have an announcement of national funding, it will see much more detail than we've previously been able to undertake around the actual estate planning, around the expansion of buildings. If we move on, thank you. What I'm going to talk about now is actually around the service model that we're proposing. This overview slide is really just to reiterate the proposals we're making is to make use of both hospital sites. And both hospital sites will provide an accident and emergency department, and both hospital sites will provide urgent care services. We will, as we've already discussed today, maintain the beds broadly as they are now across the 2 sites. In terms of Calderdale Royal Hospital, this will be the hospital that will focus on caring for people who have some of the most serious and/or life-threatening conditions and require complex acute inpatient care. The services at Calderdale Royal Hospital will include emergency paediatric services and emergency adult care. And this is the hospital where, if you need a blue light ambulance, this is the hospital that you will be transferred to receive that emergency care, unless your needs are assessed, and actually it would be better to go to a more specialist hospital such as Leeds for major trauma, or Mid Yorkshire for burns. Calderdale Royal Hospital will include the provision of complex and emergency surgery, critical care services, acute inpatient services, things like cardiology, respiratory care, stroke services, and it will provide all of the acute inpatient paediatric children's services. Just go to the next slide. At Huddersfield, as I've already said, Huddersfield will provide a 24-hour, 7-day accident and emergency service that will be staffed by doctors and will include full consultant cover and presence for a proportion of that 24-hour period and full 24-hour cover on call. And this will be the site where the A&E will be able to treat a number of conditions that may walk in, and will be able to treat and discharge patients from A&E, or should there be an ongoing need for care, it will be able to safely stabilise patients and arrange for their transfer, which may be to Halifax, or as I've already said, maybe to other hospital sites such as Leeds. In terms of the other range of services at Huddersfield, this will be the hospital that will focus around the provision of planned services and things such as planned surgery, so hip operations, knee operations, and it will also provide care for those people who no longer require the most acute inpatient care at Halifax, but do require some ongoing support before they're able to go home. And those patients, again, will be provided with a service provided by doctors and nurses at Huddersfield. If we go to the next slide, please. We've talked quite a lot throughout the strategic outline case and earlier today at this meeting about the reference and the importance of digital technology as a key enabler for these proposals. This system is one of the most digitally advanced in the UK. There is, as we've clarified today, the ability now for health and social care professionals to be able to view information about a patient's care from multiple sites, from the community into hospital, across hospital sites. And it's live data, it's live information about patient care. It's not having to wait to be updated and input, which means it is possible for us to provide the most timely specialist input for the care of patients. And that is a theme around the development of these services. In terms of the capital investment, as I said at the start of the presentation, the total amount allocated and available to us is £196.5 million. I think what's really important here, this is wholly 100% public funding. And in terms of that allocation, we know that 20 million of that allocation is for us to utilise at Huddersfield Royal Infirmary to address some of the most critical backlog maintenance requirements at the Huddersfield site and enable the ongoing use of those buildings. The 177 million investment is to allow us to expand the existing Calderdale Royal Hospital to provide additional wards, theatres and expanded areas. In terms of the business case, it sets out in two chapters, the economic case and the financial case, an analysis regarding the impact of these proposals. Those chapters are quite technical in their content. They conclude or demonstrate that these proposals do deliver an economic and value for money benefit for our system compared to us staying as we are. They have demonstrated, and through discussion with clinical commissioning colleagues, they've demonstrated that they are affordable to this system and in line with the financial and activity plans of our system. We know that they will improve the sustainability of our services by the way that services are co-located, allowing us to make the best use of our workforce and improve the resilience of our workforce and the way that care is provided. This investment, £196.5 million worth of investment, helps to mitigate some of the significant risks we have around our current estate, particularly at Huddersfield. And through the delivery of these services through this new model, they will deliver improved efficiency of care. If we move on. In terms of next steps and timeline, the strategic outline case describes what I do want to stress is an indicative timeline. We've discussed this with NHS England and with NHS Improvement, and I think this is modelling through what could be argued to be a best case to allow us to progress these business cases with the necessary governance and approval mechanisms and requirements. And what you'll see there is we're working towards an approval at the end of this calendar year for the strategic outline case. It's currently going through processes of due diligence with our regulators and will move forward. Approval around our outline business case following its development during 2021, the full business case in 2023, which would allow us to commence build in 2023 with 2-year build time completion in approximately 2025. We are keen to progress and expedite this timeline as much as we can, but as I say, it's an indicative timeline that we have at this stage. Question was raised earlier around the drawdown of funding earlier. We are actively progressing discussions that we need to access the proportion of funding, the 20 million investment for Huddersfield at an earlier timeline. At the moment, we're in that process of mechanism of approval about how could we draw that funding down and make that investment now and not wait until this 6-year timeline suggests. In terms of stakeholder and public engagement, this is a further 6-year programme of work with some very detailed design work needed around the service provision, around the estate. We're absolutely committed to continue to work closely with all stakeholders, with Scrutiny and with members of the public. There's an agenda item later today at this meeting where I know we're going to give an update regarding the further development of those plans for engagement and involvement. And I think that's the main points I wanted to pull out.
Thank you. Just before I open it up for questions, so the aim of today is to draw out themes that we would want to go into more detail. We understand that the strategic outline case is not as detailed as the outline business case will be. Equally, then the full business case will be even more detailed. Having had previous experience of these documents. Your timeline, can we just look at your timeline so we understand it before we move into questions? So you said this was your best case scenario timeline, basically, isn't it? This is what you're hoping will be achieved. But there's got to be some milestones in this as well. So your decision expected at the end of December 2019. What do you have to have in place prior to December 2019 in that decision timeline in order that we as Scrutiny can look to see what our timelines need to be? So do you have to go to various boards before December 2019, etc., or is it that it gets submitted at the beginning of December and then there's a decision at the end? Do you know what I mean? There's got to be some points of milestone, isn't there, in that?
So in terms of process, the strategic outline case has been approved by the Trust Board, and we have submitted that to NHS England and to NHS Improvement. The NHS England and NHS Improvement, along with colleagues from the Department of Health, have essentially what I would describe taken the strategic outline case and worked with us in a process of due diligence, which means quite technical assessment of the document. And we've had a number of meetings. They've asked for some points of clarification. They will use that information at a regional level and will make recommendation for the national approvals team. Our understanding is that they are intending to submit their recommendations into the national decision-making process on that business case during July, where they have then sought to model through the various committees at national level that document will have to progress through, which has led them to conclude that December is the likely timeline for that to be concluded, that work. There is some uncertainty in that I understand some of those meetings, there are not dates in diaries at this point in time, and that's why I talk about it being indicative. So people have used what is seen as a reasonable lead time about when papers would need to be ready, documents would have to be briefed, but it's not, people could not point to a calendar and say it's going to that meeting on that date at this stage.
So do we want to open it up for questions then? So who would like to start? Yeah, Councillor Simpson.
Hi, I'm Councillor Simpson. I'm a Kirklees councillor for Calderdale ward. It said on your slide, and it says in the strategic outline case, that you'll continue to fully engage and involve local people. If people are going to be fully engaged and involved, should that involve consultation?
I suppose, technically speaking, that wouldn't be our call. The conversation that we'll have later on about the work that we're doing to build our engagement approach will be something that the Joint Scrutiny Committee will want to consider, and I guess we'll be advised by the committee about whether they're satisfied with our plans.
Just to go back onto this a little bit, and I appreciate your answer there. Just when we had the last consultation, 80% of Kirklees residents said they thought that the previous iteration of the proposals would negatively affect them. I was wondering, from your take, do you think if we were to have another consultation, do you expect that would be any different with these proposals? Do you think people would feel differently about them? Or would you expect a similar result?
When your engagement and in engagement work and any consultation work that may flow, there's in your last consultation you had a 12-week statutory consultation last time, didn't you? You're not saying this time that you yourselves will have a 12-week statutory consultation. Let's just clarify this. What you're saying is that if Scrutiny wished you to do any extra work, then that would be for Scrutiny to say. But your 12-week statutory consultation is that you don't believe that you need that this time. In your work that you're going to be ongoing, last time there was 80% of people from Kirklees believed it would have a negative impact, the changes would have a negative impact. So how are you going to engage with people so that they, to try and reduce that perception? All right, so maybe, do you just want to say what you're going to do? Yeah? All right, and we'll merge the two items into one. Right,
That's
there's
fine.
a plan for
Okay.
you.
So I was going to go through, sorry, colleagues, Penny Woodhead, I'm Chief Quality Nursing Officer for the CCGs and have had the responsibility for leading our engagement and involvement work. So we had the stakeholder event on June the 11th, which we talked about in Scrutiny in February, and that was our intention was to engage with stakeholders and local people about what would the next phase of engagement involvement look like, what were the areas that we feel that we want further engagement on, and how would we do that. So it was the stakeholder session was very much about getting the views from local people and stakeholders about what we should carry on our dialogue about, where we should be doing that, when we should be doing it, and how. And the intention is then to build a detailed engagement plan in relation to that. Now, there was a little bit more detail I was going to say about that session, but shall I carry on? Okay. So we are in the process of writing the full report from the session on the 11th of June. We had over 70 people come to that session, and they were from a range of organisations and members of the public. So we'd good representation from patients from reference groups, from general practice, from community voluntary organisations. Some of the elected members that are in the room today were here, and from the campaign groups. So 70 plus key stakeholders. We had really important that we get diverse range of views in that conversation. I think we did well in some areas in relation to diversity, and some areas where we'd want to do some more work. So underrepresentation from the voice of children, young people, and from black and ethnic minority communities in that conversation. But that's not to say that there weren't voices there. But we'd really strong engagement from people with disabilities and carers in the conversation. We'd identified 5 key themes for discussion on that day, and they were drawn out of things that Scrutiny have raised concerns around, things that have come from consultation, and things that we know that we need the support and the involvement of local people in our next phases. So our conversations were about ongoing engagement with children and young people, around travel and transport, around digital and technology, clinical services redesign, and the hospital build. And in addition, we had the opportunity for stakeholders to inform the local place-based involving people plans for Calderdale and Kirklees around the out-of-hospital work that we're involved in. So as I said, there were opportunities for people to give us ideas around who should we be engaging with, so we can ensure that we've got the most comprehensive list of individuals and organisations. When should we be doing that? Where and what are the mechanisms? So we've done a lot of engagement. Our CCGs and the Trust, we do engagement on a range of topics all of the time, but this was around, are there things change and us wanting to be able to enhance those plans. So we're in the process of writing up the evaluation from that day. Some headlines. I think people felt positive about the structure of the event and their opportunities to be able to self-select the conversations that they wanted to be involved in. I think there were some acoustic issues in relation to the venue that came back, but we're going to write up the key findings from that day, and we'll obviously share that with Scrutiny. And the messages that we heard during that day will then inform the next stage in relation to an engagement plan. Again, once developed, we'll be able to share that with Scrutiny and discuss how we take it forward. And my final comment would be to say that we've very active involvement from Health Watch in this stakeholder event, which is, I think, something that we've tried a different approach this time. Colleagues from Health Watch were participating in the conversation, but also hosted their own stand and were able to independently listen to the views of stakeholders in the room. Health Watch have shared with us their report of findings, and the learning from that will be incorporating in the engagement plan going forward.
Okay, so your engagement plan, what are your timescales?
I know. So my intention is the publication of the report of findings before the end of July, and the drafting in terms of the engagement plan similar, but it will be a draft for us to do some further work together on.
Actually, you've almost asked my question, Liz, because it'd be really helpful if we could have a copy of that report before we meet in, say, 6 months' time. So it'd be really helpful to have that report once you've written it up from the June meeting. And also for us, because obviously this is a very long time scale that we're talking about, that there are certain things we need to look at certain times, and certain things it will be irrelevant for us to look at next month, because we're talking about something that's going on over years. So for us as a committee, it'd be really helpful for that to be broken down into small steps in terms of what it would be best to look at, when, and who you're going to look at them with, and for wherever possible for us to be involved, maybe even go to some of the meetings so that we can be involved in that process. So it's really important that this engagement exercise is done properly, and that we know how well it's going and what feedback you're getting systematically, not in 3 years' time. Is that helpful? Thank you.
I think we would want to, yes, have the engagement plan as quickly as possible, and we'd want time to have a look at it and have a plan a meeting to discuss it, and then we can say from a scrutiny perspective whether we feel there's any areas that we feel are missing at that time. Okay, but I know as well, because something was said about digital services. And as I understand it, I think I've seen something that Health Watch have just done a piece of work for you on digital services. Is that right? So, Helen, I know you wanted to come in. Are you going to, is that work on digital services going to be part of your engagement, etc., on this strategic outline case? Because there is now a dependency in here on your digital services. Helen?
Never sure which button to press, sorry. So I assume that the work that you're referencing is the work that we did around how the electronic patient record was working, which was done, I think, about 18 months ago. It was always completed then, but it was a piece of work that was requested from us by CHFT to understand how the initial implementation of their EPR had impacted patients, and that's certainly something that I would expect to be considered in the development around the engagement and gathering of people's views.
So I was just going to say, I hope Helen doesn't mind me referencing, we are working really closely with Health Watch around the use of digital technology in some of our pathways of care, such as outpatients, and about how that's experienced by patients, and helping us really to make sure that we get our impact assessment of that fully understood, particularly for more vulnerable members of the population. So I think that will definitely help to inform as we move forward over the next 6 years. You know, in 6 years' time, what will our provision of services look like? And for some people and for some services, being able to access those services remotely using digital technology will be a key benefit to them.
Yeah, I was just going to mention the fact that from a Kirklees perspective, we've been leading a piece of engagement work in relation to the long-term plan, the NHS long-term plan. From an ICS perspective, the integrated care system, a number of areas have taken the lead around particular chapters. One of the really detailed pieces of work has been around digital. We're in the process of writing that report up. I think it will be definitely something that place-based scrutiny will be interested in, but it might be that you're interested in here, and we'll be taking the learning from those events into this plan as well. So I think it's really important to say that none of these things happen in isolation. We need to be able to draw on the experiences that we're picking up via a range of engagement activities, and that's what we'll be doing.
I think as well the point was raised, wasn't it, about how you're going to interact with members of the public, because there is a great deal of feeling that these proposals negatively impact. So in your engagement plans that you're working on, are you going to be engaging with members of the public, with service users, with people who are coming into the hospital and asking them how have they travelled there, what difficulties have they had? Are you engaging with people who maybe have been readmitted and why they've been readmitted, etc. And what's your model of services? You've said you wanted to engage people with the delivery of services. So where does that delivery of service engagement start? Does it start now, or does it start later on further down the line? I know there's a few questions there, but
what I would say is that we're not at a standing start here. We engage with patients and service users, members of the public, all of the time in relation to design and delivery of services. So what we're talking about here is the specific elements of our plan and the enhancements to that as well. So I think some of the suggestions, some of the areas that you've said, Councillor Smage, there were exactly the things that we were asking the stakeholders about on the 11th of June. What should we talk about with you? When shall we talk about? What are the mechanisms? And where should we be doing that? So, not the reliance on you coming to us, but us going to you, to various groups to talk about it, using the opportunities where people are interfacing with health professionals to gather views. And it really does depend on what the topic is as to what the mechanism what the best mechanism is around that engagement. So we will detail that in the plan.
Is there anything more on the engagement side of things, because then we can move on to the SOC?
I do agree that we need to be fairly clear on the timing of the various engagement or consultation events so that there is sufficient information there for members of the public to actually consider, rather than sort of more nebulous concepts, because otherwise you're not going to get clear answers from people. So it will be a matter of judgment as to where in the whole of this planning process those events take place. And that's something we would like to work with the CCG and the Trust to actually establish a plan of public involvement.
Can we move on then to some points on the questions on the actual strategic outline case? First of all, you mention in your strategic outline case about care closer to home, demonstrating services are developed in the community and demonstrate a sustainable reduction in the demand for inpatient hospital care. That sentence is used quite a lot of the time through your SOC. And this goes to care closer to home. Okay. Now, can we clarify that the place, the Kirklees standing panel and the Calderdale standing panel will need to discuss care closer to home in those areas. I know that the Kirklees one is obviously split across 2 acute trusts, and any changes that are made to any contractual relation in respect of either Calderdale or Kirklees would need to go to the standing panels in those areas. The JOSC needs to test that you have the evidence to say that those care closer to home plans can demonstrate that sustainable reduction. Okay, so we need the evidence to say whether your plans are going to be sustainable with the care closer to home. It was a major concern that we had, and it is also brought in with the IRP. And in looking at the scrutiny going forward, this scrutiny panel needs to test both our concerns and the IRP concerns to see whether they've been addressed. Okay. So as far as care closer to home is concerned, I would expect that we would want a piece of work on care closer to home in relation to how it supports these reconfiguration plans. Okay. Did you want to come in?
Of course. Yeah. So we fully accept and support the requirement that this body has to be assured about the impact of our plans on the activity that happens in the hospital part of our system. Understand that very clearly. I guess there's just a question in our minds about the mechanism through which we provide that sort of information to the Joint Scrutiny Committee. If we are able to provide that information to our local scrutiny arrangements, then the Joint Committee, I guess, has got a choice to receive that information from local scrutiny or to require us to present again. What I'm concerned about in the middle of all of that is the duplication of effort in the context of some real pressure on particularly CCG running costs that is coming into play over the next 6 to 12 months. So I would ask the committee to be thoughtful and careful about how you expect us to interface both with joint scrutiny and with local scrutiny arrangements so that there's a minimisation of duplication.
Yes, we will be thoughtful in that process, but thorough in our evidence gathering.
Thank you. Certainly, as people have said before, the NHS is awash with data but very little information. And so we would want to look carefully at what would be the essential bits of information that would allow us to assess whether the local healthcare system is on an appropriate trajectory to make the planning assumptions valid. And I would have thought that this committee would like to have an informal workshop with the CCG and the Trust to actually define what that dashboard of data would look like, so that we can see the trajectory that is being followed, so we can be assured that the plans have will provide the services that local people need in line with the first 2 measures, first 2 requirements of the Secretary of State. But obviously that kind of detailed discussion isn't something that we would do in this kind of meeting.
So understand and fully accept that, and we would have a common agenda in that space. As well, clearly we need to be able to demonstrate to ourselves and the people we're here to serve that we are confident in our plans. So that's all fine. I guess the question in my mind is about the relationship between joint scrutiny and local scrutiny. And if we're in the business of creating an informal space where we can do some work together, will the Joint Committee consider its relationship with local scrutiny and consider whether there would be some value in bringing all of that together to have a single conversation about how we work together?
Yes. It's a bit difficult for me because I'm no longer lead member for the standing panel, but yes, we will look at that. Okay, all right. The report into plans to reduce bed days that you've summarised in the SOC. There is a full report on that. We understand from the text in the SOC. So, is it possible to have the full report on that for our deliberations, please?
So, I mean, I can reassure the committee that report, so there's an independent report produced, that's freely available on our website. And again, it's back to where do you want to have the conversation? What I had in mind is that there would be more detailed conversations about the implementation of community service integration and new models of care in local scrutiny arrangements than there would be here. But we're very happy to make that report available. It's freely available on the CCG website.
Fine, thank you. And can we ask as well, the Clinical Senate was involved way back in 2015 on your plans at that point in time. Are there any plans to discuss these SOCs with the Clinical Senate now in 2019?
So, as we move through from strategic outline case through outline business case and full business case, there is a proposed quality and safety assurance panel that will be established. That will consist of people from CHFT, from the CCGs, but also we will bring in the relevant specialisms from either the Clinical Senate or the clinical directorates at NHS England, NHS Improvement, and YAS, and others, as I say, as we're going through what that more detailed work in terms of the protocols and the mitigation. That's how that will be brought through.
It would be interesting to see that in a little bit, a bit greater clarity, because, and the question would also be at what point that work would be done, because there needs to be something. The Clinical Senate last time said that they found it very challenging to assess the risks due to the visionary style of the documents. So one would hope that they could be presented with documents that were a little less visionary and a little bit more hard-edged, so that they could actually assess them, give a more considered opinion. So at the point at which that takes place will be important, and I think it's something we would probably have a view on.
Primary care networks. So, as part of your engagement, etc., and your ongoing work, how are you interacting with your primary care networks and your local medical committees, etc.?
So sorry, I'm Carol McKenna. I'm Chief Officer for Greater Huddersfield and North Kirklees CCGs. Shall I just say a little bit, first of all, about primary care networks? Just to respond, I think, as well to one of the comments I heard earlier about primary care networks being introduced without consultation. We have always had, well, we have for the last few years, had an approach in both our CCGs where we have recognised the value of general practice increasingly working at scale. So in the past, general practices have been very standalone organisations, and because of the sort of well-documented pressures that we see in primary care, it started to make increasing sense for practices to work together on certain things where possible. That local approach that we and others were taking was actually reinforced through the long-term plan that was published at the beginning of this year, and it was strengthened by the introduction of the new GP contract agreement, which took effect from the beginning of April, but was signalled a few years earlier. So primary care networks are not a Calderdale and Huddersfield idea in that sense. They are a national strategic direction, and they have now, as I say, been embedded in the national contract framework for general practice. As part of that national framework, primary care networks were actually only formally established from the start of this week, from the 1st of July. So I think maybe there is a sense that they are up and running and fully mobilised, and lots of things are happening. They are very, very new partnerships. In terms of the engagement generally, I presume what you're doing is asking me about engagement on these proposals with primary care networks. We maintain an ongoing dialogue with our practices on a whole range of things all the time. If I take the LMC, we meet with them monthly. We'll continue to talk to them about this process as it moves forward in the way that we always have done. And I know that colleagues in the Trust also have a regular dialogue with the LMC. With primary care networks, we're at the point where we're talking to them about how we will work together. So if I use Huddersfield as an example, there are 5 primary care networks in Huddersfield. Each of those primary care networks has a clinical director. It's very clear in that national role outline for those clinical directors that they are expected to have a role in working with us and the ICS, for example, on clinical strategy. And I know in Kirklees we have an introductory meeting planned with them later this month to start to talk these things through. So they will be absolutely key partners in terms, as we move forward and as we work together, and we'll maintain a dialogue with them about this programme as we will do about a whole range of other things.
Right. Can we ask then as well, in your SOC you've got about the demand and the health inequalities, etc., in pages 2 and 3. Well, it actually says 3 and 3, but your strategic context. So how are you setting your proposals against what your outcomes you wanting to reduce those health inequalities? How are you quantifying that? Because I don't see it necessarily in the SOC as to how your proposals that are there will actually make a difference to the health inequalities that you've outlined that are needing to be addressed. So, for instance, it's saying for both Calderdale and Kirklees that there's an expected increase by about 75% over the next 15 years for people living with dementia. So how in all of these proposals are you taking account of all of these health inequalities? Am I making sense? Probably not. But if you've got rising levels of dementia, if you've got rising levels of population, if you've got rising levels of obesity and changes in life expectancy, how are these proposals going to help those outcomes in the longer term? Because I know it's not a 5-year thing, I know it's a long-term proposal, but how are your plans hoping to address those health inequalities?
So the strategic outline case and its primary purpose is about the description of a new model for hospital services. It cannot and must not be taken in isolation of all the other work that we're doing at local place and across the West Yorkshire and Harrogate Health and Care Partnership. In terms of speaking directly to the mental health agenda, I think that the change that we are trying to promote in terms of the way that we're working as an NHS with partners is that we're trying to break down the barrier between physical and mental health. And we've done a lot of work in this system to do that. So we've got good liaison in accident and emergency departments with mental health staff who are supporting acute services in managing those challenges more effectively than I think we were certainly 5 years ago. So there's a recognition of the need to change the way in which we are delivering services to speak more clearly to that sort of agenda, but I'm not sure that it's reasonable to expect a strategic outline case for a hospital change to speak in detail to all of that. I think that we need to look to other strategies and other delivery plans, particularly those that are within the purview of health and wellbeing boards, and draw upon that in the same way as we draw upon engagement and other information to describe the whole of this. This is a part of a bigger piece of work and thinking.
Yes, but equally I wouldn't expect it to work against those local plans. And so if you're saying that your demand for certain services is going to increase over the next few years, because if you've got all of these health inequalities that the local places are trying to address, and your services that you're proposing going forward do not take account and try to help those health inequalities, your demand levels then are not going to surely work as you would have hoped. So it is how those health inequalities are taken account of and helped, not worked against, as part of these proposals that I want to know.
So again, Anna, you may have more on this than I am about to give, but I think in shorthand, that's what we mean by demographic growth, and that's how we're taking account of the growth in demand by working collaboratively, delivering enhancements to community services, delivering integrated community service provision, and changing cultures, but taking account of, as best we can, the impact of all of that on the requirement for hospital beds.
Thank you. The Trust has been in receipt of a new structural survey of Huddersfield Royal Infirmary, I believe. Obviously that then has a bearing on how the 20 million is used to best effect, and to what kind of changes we might anticipate on the Huddersfield Royal Infirmary site. Can I ask that this committee have sight of that structural survey so that we can then take the plans for development into context?
Yes, in fact, the findings of that survey are available now. They were published last week as part of our board papers. Our board meeting was today, so they are available on the Trust website, or I can send them directly to Scrutiny officers if that's easier.
And we have heard that there are continuing concerns about the transport and access analysis that has been done, which, to my reading, very much is based on saying, well, if you've got to Huddersfield Royal Infirmary, it would take you a certain number of minutes longer to get to Calderdale Royal and vice versa, rather than saying if somebody is setting off from, say, Walsden to get to Huddersfield Royal Infirmary by public transport, what difference would the fact that they'd have to go to Huddersfield Royal for certain services have compared to if those services were based at Calderdale, and vice versa for somebody who lived outside of Holmfirth, having to get to. So the way that the report is phrased is with a single average figure. It doesn't show a range of figures. You know, and it's unrealistic to expect somebody using public transport to make the effort to get to one hospital and then find a way to get to the other. They would use public transport to get to the hospital that they were intending to go to in the first place. So I think we would value some input into the design of the analysis of this information, because it is access to services is crucial to local people, and this is something that's been coming up over and over again, and we need to be able to give people a realistic idea of what they could anticipate in the future.
So, as we've already established, this process and conversation has been going on for 7 years now, and some of this gets lost in the mist of time. I can't honestly remember whether the Joint Scrutiny Committee considered the Travel and Transport report.
No, I think we were going to, and I think it wasn't ready at the time, and your independent chair couldn't come to the meeting. I think that's what is the confusion, because we need to consider that Travel and Transport report, and we need to understand on what basis, at what point in time that's been taken, okay? So one of the things that was mentioned, I noticed from your paperwork, was that the Travel and Transport group that met and deliberated over the information, because you have had an independent chair, haven't you, look at it. One of the things was for the shuttle bus, for instance, to be improved now rather than later, and things like that. So I think we need to look at, to explore that, and for whoever can come to talk to us about it, to actually come to talk to us about it. But also I noticed there was some points raised about highways, and that isn't yourselves that would be involved in the changes of highways. So we will take that on board, okay? Because yes, it's not the CHFT or the CCGs that say whether the roads get changed, okay? But we will take that on board and have some evidence on that, okay? But you did have an independent Travel and Transport report, and we need to look at that, okay? All right. But your shuttle bus, have you made any improvements on it since at all?
We've made some improvements, I believe, around some of the scheduling around that, but it is part of a wider review which would need to provide a scale of public service again. It starts to fall into the provision of a wider public bus service and the interface with transport services. So it's part of the ongoing work that we need to take forward around transport infrastructure.
Would you not feel that it might be a positive thing to actually improve the accessibility of your shuttle bus going forward? I understand you've done some timetabling changes to help people who have to, at this moment in time, go to Calderdale, between Calderdale and Huddersfield. Yeah. Would that not be an improvement that could be looked at earlier rather than later?
I think it is something that could be looked at earlier rather than later. I think there is a real question about, if you're talking at scale, the provision of a bus service for the public. Again, you just referenced, is the hospital trust the best provider of that service? So, but definitely it's a service to support people in the use of healthcare, but there are you'll probably know better than I do, a number of regulatory requirements regarding the provision of that type of public scale of bus service. So it is a development that could happen earlier, but it's not a straight, it's the trust provision should be assumed in that.
So, on the other side of Kirklees, there was a shuttle bus that used to go between Dewsbury and Pinderfields, and people could use that shuttle bus. I think predominantly it was staff that used it as well. And as part of the changes there was a service put in, and it was put in conjunction with Metro as it was then. I think it's the service 113 that now runs between the three hospitals. So what you're talking about is a service, yes? I think what we were asking was your existing shuttle bus, which is provided by CHFT, is it? And members of the public can use that shuttle bus to go between the two hospitals. Can that be made accessible in the meantime when you're looking at, as you said, the at scale for whether there would be a need for a regular service provided by a commercial provider? Yeah? Were there any other points that we wanted to raise at this moment in time?
We've previously established that the committee would like as much advance warning of changes of service provision between the two sites in terms of bed numbers, distribution, specialty distribution. But that does also extend to diagnostic services. My understanding is that there's a proposal to move the Eurodynamics service from Calderdale to Huddersfield, which would obviously have an impact on patients in Calderdale needing to access that. Is that correct? And if so, that I would see that as being an example of things that we would like to have be able to look at before they actually happen.
I don't think we have the answer to whether that's happening at the moment, Colin. We can find out for you. It's not a conversation I've been directly involved in. But clearly we do move at times small parts of the service for operational reasons. We're happy to get the information for you and provide it to you.
I think it's useful that we can feel confident that we know what's actually going on and what isn't going on. So I know providing information about a negative is not something that you can say, but as long as we can be confident that we know about the things that are going ahead, that would be fine.
Yeah, I think we provided information at the last meeting which said that we had no immediate plans to make any further interim reconfigurations. I mean, clearly that will not extend to some of the smallest work that we do on a day-to-day basis to maintain service continuity and deal with clinical pressures.
So I think we'd need to know if, for instance, something changed and you needed to, a service needed to be looked at in the interim that was part of the overarching changes that you would want there was a need to move it for safety or for whatever else. There was a need to move that service sooner rather than later. I think we would need to understand what the impacts would be.
But there has to be a test of proportionality, and there has to be judgment exerted on whether there is operational change required. I'll say this, you do need to trust us to exert some judgment on what we think we need to talk to you about. I think we've had a long enough relationship in this conversation to be able to exert a reasonable judgment on that.
And can I just say that obviously you will, as you would always do, I am sure, if you needed to stop a service for a temporary period of time, or you would need to change a service under the safety things, you need to let Scrutiny know, the local Scrutiny know. You came to us, Scrutiny, and you said you needed to move cardiac and respiratory in earlier than the plans. And we looked at that and understood the reasons for that move. I think what we're asking is that we understand if there is anything else that is moving in the interim. I think that's what you were asking, Colin, wasn't it? Yeah? Okay.
And I'm really asking you seriously, are you telling us that for every change that we might possibly make for operational reasons, so proportionately and with judgment?
I think that's what we're asking. You moved two services, respiratory and cardiac, from one hospital to the other. That was something that you needed to talk to Scrutiny about in any case, okay? And all we're asking is that you let us know, okay? All right? So that we can understand the impacts of those changes. Councillor Collins, you wanted to come in.
Sorry, mine's not a question or a comment, except to say that I have a hearing difficulty, and if as chair you speak to the officers over there, I'm sure that people over here, and certainly I cannot hear. So unless you face forward, the microphone does not pick up your voice.
My apologies. Thank you. We'll sort that out for you. Right. Is there anything else that anybody wants to discuss? No? Okay. Can we move to next steps then, please? Are there any themes that anybody wants to look at as part of the next steps that haven't already been covered in the questioning? I think we've covered care closer to home, we've looked at primary care, finance, travel, ambulance hours. We haven't mentioned ambulance hours. Do we want to look at ambulance hours at all? Ambulance service, impact on ambulance service. The West Yorkshire perspective, we haven't mentioned travel and car park in the estate, we've mentioned the estate. The clinical centre, we've covered that. Engagement, we've covered that. Anything else? Primary care workforce? No? Colin, do you want anything?
The main thing was the metric, establishing the metrics that we would use we would agree that could demonstrate whether we were on track to meet the requirements.
So is the committee content then that we work with the CHFT and the CCGs to look at the timings of such information coming to scrutiny? The joint chairs meet with the CCGs and the CHFT to discuss the timetable and put a plan of meetings in place as to the appropriateness of the information coming forward at the right time for scrutiny to look at. Is that what we would like to do? Yes? Okay. Is there anything else that we need to cover as part of the next steps? We would obviously like the engagement plan at the end of July when that's available, and we will put a meeting together to look at engagement, and we will say if scrutiny feels that there needs to be anything further in that engagement. All right? Okay, thank you very much, everybody. Thank you.